Well, I'm always impressed to see so many people here and so many friends. It's always a pleasure. And thank you for this invitation. It's always a great time together, and I really appreciate, and being here is a privilege. So, well, I've been suggested to talk about a difficult topic where there is a lot of things to say or nothing. So we will take the option right in the middle. The question is, and that's a very hot topic, it's very fashionable, so to speak, at the moment, is the story of the non-invasive stimulation. And, well, is it something which is near to be a treatment, or is it something which is still in the research lab, or what else? And if you see the second title, just underneath my first title, it says almost everything, which is pathophysiology or experimental therapeutics, which means that these techniques, with an S, has been mainly developed to explore the pathophysiology of dystonia, with an S, again, all the different types of dystonia. And until now, it's mainly in the field of experimental, that is research therapeutics, at least in the field of dystonia, because it has been also tried in other fields like stroke or cognitive disorders. So I hope I make it right. So we are in competition with the non-invasive stimulation, with botulinum toxin, we just heard of it, with deep brain stimulation, the big winner, with drugs, not too good, and we will see this afternoon physiotherapy. And you see that it's a kind of stone age, because you see this gentleman holding this stick, so we are at least at that stage, and except the fact that on the t-shirt we have this Superman sign, I'm not sure that's a Superman by the time being. So is it a therapeutic effect? Is it only hope at the moment? Or is it already reality? And I will spend some time to go through the techniques because they are a bit obscure even to me. And maybe it's easy to know about it because sometimes we read the papers and it's a bit fuzzy to us. So we have to clarify what we have to think of it, at least from what I try to do for you today. So the starting point is, will non-invasive stimulation match the beneficial effect of current available treatment? And I would like to know if somebody thinks yes. Okay. Who thinks no? Nobody has any opinion. I think at the end of the lecture you will have. Well, by the time being, the answer is no. There were so potent treatments, botulinum toxin and deep brain stimulation, that to date, there is nothing that matches this level of efficacy. And currently, the main use of these techniques of non-invasive stimulation may be associated with neuroimaging, because neuroimaging gives you an idea of the network, or EEG, it gives you an idea of the timing of the activation of the neuron, and that's very good for timing on the very short time scale. And they are mainly used to understand the pathophysiology. So these papers appear in G Neurophysiology or things like that. So the objective first, and it's still the objective with this technique, is to identify first and decipher, if we can, the dysfunction at the individual level, and provide, if we can, the care based on what we found, that is for each person characteristic. So in a fairy tale world, we are now at the standard guidelines with the general population. The clinical reality, and we see it here, is that we all are slightly different from one another, or very different from one another. And the world that we are heading to, hopefully, is that we have an individualized medicine, and we try to give a treatment which is really targeted to groups which can be defined, or even person at the individual level. If we put that in another way, we want to identify, and we're not yet to that stage, and provide this care. So most, at the moment, even for deep brain stimulation, it's a kind of one-size-fits-all approach because we have one technique, the validol simulation. We try to refine as much as we can, and maybe Marwan will not agree with that, but I think that we have a very successful treatment, but we apply more or less this treatment to maybe very different types of patients. And the idea is really to tailor that because we try to find the characteristic, and we hoped, depending on how optimistic we are, that we can do that with this technique of non-invasive neurostimulation coupled with neuroimaging and neurophysiology. So what is the roadmap at that time, right now? We want to modulate the network excitability because we know already that there are abnormalities in people with dystonia of this network, the whole brain, excitability and function. So first of all, we want to identify the network. It's not only this technique that will identify the network, but it's a technique that helps also. So we identify that initially with MRI, all this technique of MRI, and we saw that in dystonia, we have abnormalities of structure and function of the cortico-basal ganglia network, more recently of the cerebello-thalamo-cortical network, then of the cerebello-basal ganglia network, and also something which is even more recent from the intercortical networks, that is, for example, from the primary motor cortex to the anterior cortex, which are the premotor prefrontal, and to the lateral cortex that integrates the body shape, for example, which is the parietal cortex. So now there is a lot of interaction within the brain, and each of them has a very different dysfunction from one another. So the thing is, not only we have this function which is modified, but there is a pattern of activity and the plasticity and the response to one activity and one function. So we want to modulate that, and one of the things is to modulate the signal that is fed into this network. So how to modulate that? With TMS, transcranial magnetic stimulation, and I will show you how it looks like. We send something which is not painful, and it can be just one shock, single pulse, several shocks in a row, which is repetitive transcranial stimulation, slow or more or a bit rapid. And we can also have a kind of pattern stimulation, which is called theta burst. And then we could have a continuous stimulation, which is TDCS, direct continuous current stimulation. And also we can have the plus and the minus, which are one side or the other, which is anodal and cathodal. But on top of that, we have things which are very important. At the time being, some of them are stretching. Some of them say, oh, wow, where are we going? So they are just floating. Some people are thinking to their mother, and the others are paying attention somehow to what I'm saying, and some are writing. So there are different activities, and all this activity gives a different setting and a different excitability to the areas of the brain and to the plasticity of this brain. Things are going on at the moment. We are making connection, learning things, having kind of attention, or in contrast, less attention. So we are doing things, and there are actions, and they are thinking, and they are learning. And we have different ages, and age matters in terms of plasticity. So altogether, if we put the signal, which is exactly the same, on brains that are doing different things and have different characteristics, and on top of that have different age, we will have different response. So that's why it's very difficult to just unify what we will see, because we are not dealing with the same conditions. So we will identify the network, and already it's something. I took this map from Lyon, a very nice place where there will be a conference in August on movement disorder, and you see that it's very, very crowded. So we have structures, two towns, with two different towns, and we have roads that go from one to the other, which is networks. And the most important thing is what is going on with these roads, and that's a traffic jam. So that's a neuronal activity, and in dystonia we have abnormal signaling, loss of selectivity, abnormal cortical plasticity, and abnormality of the connectome, and we go back to that. So we want to play with non-invasive stimulation on one or the other. Why I'm talking so much about it? because it matters, because it changes results, and because it makes the interpretation so difficult. And that's the main message of it. So we already talked about the networks, and that's something which is a bit more new, which is the connectome. I believe that you heard about that because it's a big brain project, and that's something which is ongoing. But the connectome is a social network. We consider the brain like a social network, so we have hubs where there is a lot of connection together, a lot of people talking to each other, and there are places where there are only 2 or 3 people talking to each other, but it may be non-important or very crucial. For example, when the president of the US is talking to the president of Russia, there are only 2 people talking, but it may be important. When there is a demonstration in France that blocks the whole country, they all talk to each other and it goes nowhere. So, well, that's why I was late yesterday. So it means that it's not something which matters. It's not the numbers. It's the importance of what's going on between these neurons, the synapses. And some of them are not talking to each other, and they should. So having said that, you can have this thing, which is a connectome. And maybe instead of going onto the network, we have to identify these hotspots and maybe have a stimulation, a modulation of these places, because that's the one that matters. So we refine to a deeper level, just not overlooking the whole network together, but where it works and what it does. By the time being, we have only 3 main targets, which is the motor cortex here, the first place, the deep brain stimulation, Marwan and Laura talked about that, and the third player, which is really interesting, which is the cerebellum. And the cerebellum is very interesting at the moment because it has several functions. Until now, we only heard about the cerebellum when we drank too much because we were walking like that. But the cerebellum is integrating the motor information, the sensory information, the multimodal information of different afferences from different sensory information. And also there is a cognitive cerebellum, which is also important. And it's a place that gets the information and computes the information online. So it's something which is very old, because there is a cerebellum in birds, but it's very useful. And that's something that gets more and more important and more fashionable in neuroscience. So the main objective with this non-invasive stimulation is to stimulate, modulate the activity of the cerebellum. It's not done very often, and it's quite complex, but I leave that to the neurosurgeon for neurosurgery, for example. So now we go to the heart of the story, but if I spend so much time to go to that point, it's because now we see that we have minimal things to say later on. So the 2 techniques are TMS, and you already see that it's something, oh my God, where is gone? Oops, my God. Go back to reality. Here we are. Non. Qu'est-ce qui se passe? Because it went upside down. Anyway. No, it's okay. It's up. Sorry about that. Again. Okay. Prof here. Sorry. My brain dies. My brain is dying. Remember that? It's in one of the Stanley Kubrick film. But I don't know how to sing Daisy. So you see, one of them is in the laboratory because it's a TMS, and one can be more wearable, and that's the one which is TDCS. What does it do to the brain? TMS. TMS, you see the loop. I don't dare to do anything now. Yeah, you see this loop, and it gives this impulsion that you can have, as I told you, high frequency over 5 hertz, low frequency, less than 1 hertz, and that it decrease or increase the cortical excitability. And you know that the cortical excitability is disturbed in dystonia. And you can have something that you imagine that can be a signal which is relevant to the cortical activity, because we know that we have the beta band, gamma band, so we have a certain rhythm within the neurons. And again, we try to have either inhibitory or facilitatory effect with continuous or intermittent TBS. And for the TDCS, the continuous current, you see that it's a large patch of stimulation, so it's non-specific, it goes over a large part. Again, you can have something which is continuous, or you can have something which is intermittent, which is stacks. So that's the main technique available. So at the time being, the idea is that, as you see, it modulates the activity of the brain, either excitatory or inhibitory. So you see that the main objective at the moment is to modify this cortical plasticity, which is one of the hallmark of dystonia and which is altered. And you see that when we restore this cortical plasticity, you may improve dystonia either by, for example, physiotherapy or deep brain stimulation. So if we take this paper that has been done in Queen Square, and it's Rouge and also Steve Tisch and other people after that, they studied if the plasticity is changed by deep brain stimulation. And the answer is yes. So you can find that, and it is tested by TMS, which is one of the non-invasive technique. The second thing is, because we know about that, and so in that case, this non-invasive stimulation technique may be used to detect which patient has the best or the most flexible plasticity, and maybe one of the people who could have the best result after one interventional therapy. Well, that's hope. It's not always reality, but what they found in this study, that when the people have a better restoration of the sensory motor plasticity, if you turn off the stimulation, they have a longer remaining of the beneficial effect, as if the brain has put itself or herself into a better condition and could hold to the normal function. And people who have less plasticity, they are not able to change their state. They may have less facility to store the best movement, the best motor program, and that's more difficult to get the best result. That's a bit a kind of summary. It's not that simple, but it means that these non-invasive techniques may not be useful at that stage for treatment, but for prediction or for refined analysis of the inner capacities of each person, which is already something. The second thing I said that the cerebellum is a very important structure, so we tried to modulate the cerebellum. The Italian did that, and after that everybody did that, and John Roswell, of course, did that. And that's Sabine Meunier, who is a very creative researcher in my team, and she tried to do that to a young lady. So the modulation was from the cerebellum going to the cortical area, which is the motor area, and the cerebellar stimulation modulates the activity of the cortex in normal subject. I mean, non-dystonic subject, because we are all normal, but some of them may have these difficulties with their plasticity. So if on my brain they do that, they will change the state of my motor cortex. So there is a cerebellar cortical modulation. Unfortunately, in people with dystonia, we hoped that if we modulate the cerebellum, we will modulate the activity of the cortex and improve the dystonia. And unfortunately, we failed. So we tried to do that, and we realized that it was very difficult to modulate the cortical activity. So this was ineffective. And whether we used an inhibitory or an active excitatory pattern of stimulation. So there was a loss of cerebellar control over the cortex. We could not use in this particular subject with writer's cramp and in this particular condition this technique to treat these people. We had a little bit of effect on physiological marker, but the people were not good or even better for doing this manual task. So there was a bit of a concern, but that have science going. So by the time being, we are struggling, not us, but not only we, but other people, we are struggling with this particular technique. So can we have a group of people or a group of subtype of dystonia that will have a better effect of this kind of technique? And the answer, by the time being, is more or less no. It has been tried in these children, and in children it's rather disappointing. They may have a little bit of subjective improvement. Sometimes people who are very optimistic that there is some effect, but altogether, if you look hard into the data, it's not that spectacular, and it doesn't match other treatments. It has been tried mainly in hand dystonia, because hand dystonia is difficult to treat with botulinum toxin therapy, so people were very hopeful with non-invasive stimulation, and also in cervical dystonia and blepharospasm, but less people. And there are very, very few case control blind studies. That is, there are very, very few studies that has been done on a very strict and rigorous condition. And all of them have small number of patients, different type of stimulation, only one stimulation that does almost nothing. If there are several, we have different way of doing that. They have different age, and the plasticity of the people, of the cortical plasticity, differs from age. More plasticity when you're young, less when you're less young, and so on and so on. So it's very hard because none of these studies are comparable, and from all of them we get a little bit of effect or nothing. And all of them are not long-lasting. And that's either with TMS or TDCS. Well, that's the way it is. So I take a few examples, and for example, if we do slow RTMS, it was on writer's cramp, and what I find is mild modification of writing, that is less pressure of the pen, better stroke when writing. Well, all of that is not spectacular, and it was a very modest effect. When they did TDCS, again, we set musician, and we have something with musician, guitar players, or in pianist, they had a little bit of improvement of some movement in some particular condition, provided they did another movement at the same time, which means that's very restrictive when you play Rachmaninoff on the piano. So in a way, it didn't help that much. And my feeling at the end of this long story, which is long to say that we are not on the way of a treatment right now, is the most promising thing, if any, is first, it's a really remarkable tool for exploration of the pathophysiology and define the characteristic of each, if we can, individual person, and try to find how to adapt the treatment or to adapt even what we say to the person at the individual level. So it's powerful to understand the disease globally and at an individual level, maybe. The second thing is it comes from the stroke and the cognition. In stroke, people have used a lot of these techniques, especially TDCS, because it's wearable, and it's always associated with physiotherapy. And in that case, the idea is that it may help. And that's very important, because what you understand, if I was clear, which is not true, from this story, is these techniques set the brain in another condition. So it means that it's like when you wake up, you increase your arousal and you increase your attention, so you set your brain in a different condition to get set, to get ready, and to go. So in that case, it's like in fencing. Get set, get ready, go. Hein? Allez, go, allez. Hein? Voilà. So in the past, fencing was in French. So in that case, you set your mind and you set your brain in a different condition thanks to one of those techniques. And on top of that, you do something out of your brain, with your brain. So in that case, it may be helpful to add these two techniques, physiotherapy or training or self-training or even drugs and this kind of technique. And in that case, that's one of the ways on which is working the group of people working on physiotherapy and stroke, and again also in neurodegenerative disorders, there are people who are working on very rare disease like progressive aphasia, and they had training with cognitive training and language training and very fancy things that I even don't understand. And they had a little bit of improvement of the verbal fluency, that is the number of names they can say in a minute. You will say that it's not jackpot. You don't have the jackpot with that, but at least it helps, and there is something. And I think it's worth going along that path to understand what we can get out of these techniques, either knowledge or treatment or both. And having said that, I will conclude at the end of the message. It's still exploratory, and exploratory studies are needed, but they are needed to understand what it does, how it does it, what is the difference in different people, and what we learn about the brain. The second thing is, until now, there is very few studies on the double association, and it's not easy to design this study with one treatment plus the other, or one intervention plus the other. My feeling, but it's only me thinking that, I don't want you to buy that, but it's open to discussion. These techniques may be a complementary rather than an alternative treatment. And at the current stage, non-invasive stimulation cannot be recommended, or people cannot just dream of it for therapeutic use in dystonia. It's not a negative message. It's a message full of hope, because it's one of the ways to understand better each of us, each of you, and that's what I'm heading for the rest of my life, if I live long, and even if I don't live long. Having said that, thank you, all of you, for being here. It is a wonderful time. We had 20 years of great adventure. We are ready for more. Let's go for the 24 more years for those who are young, and jump for all. Thank you for your attention.